cirrhosis is bad. What labs do you think of?
CMP, like ALT.
Yeah, so AST to ALT ratio is important. What is the mnemonic there? Another Scotch and tonic.
Oh, that's it.
Yes. What other labs am I thinking about?
Alphos.
Yeah, so alk phos is more specific.
Cute. I feel like we need the, what's it called?
What's okay, good. We're going there. What's this more specific for, the alkaline phosphatase? What's it even more specific for? The common bile duct, actually, yeah. So common bile duct pathology. What else? Other ones? Common. Let's go common labs, and then we'll go down your road, because I like where you're going.
Bilirubin?
Yeah, bilirubin, right? So how do I sparse out bilirubin?
Direct, indirect.
Yeah, direct and indirect. Which one is indicative of a hemolytic process?
Indirect.
Yeah, indirect. Which one is indicative of the function of the liver? Direct, because that's what the liver's doing. It's conjugating the bilirubin. Okay. Now, what you were saying, synthetic function. So how do I know if my liver's working? What labs do I check? There's two big ones. So albumin's a good one. Yeah, actually. I wasn't even thinking that. Good. I like that. What's another?
Coagulation factor.
Yeah, so the coagulation.
INR, yeah.
Yeah, so we look at INR, if they're coagulopathic. And then what's the other one that I talk about? And it can cause encephalopathy. And we're going to talk, ammonia. So let's keep our minds on ammonia for a second because of what we were just talking about. So tell everybody what this is and what it's for. Tips? Yeah, so transjugular intrahepatic portocaval shunt, okay? So transjugular, so you're coming from the IJ, you're going down into the IVC and into the liver, okay? And you're doing, so then you have, what makes the portal vein?
Splenic vein.
Okay, here's the splenic vein, okay? What drains into the splenic vein? The inferior mesenteric vein. And then the confluence of this and this is what? SMV makes the portal vein. What's in the triad there? In the Jesus Christ. Hepatoduodenal ligament. I was saying gastroduodenal.
Common bile.
Yeah, so the CBD, common bile duct, portal vein, and what's the other thing? Hepatic artery. And what's the maneuver in trauma when I clamp this thing? Pringle maneuver, okay? And if I still see bleeding, this is actually a good drawing. If I still see bleeding after I do a Pringle maneuver, where's it coming from? Yeah, the retrohepatic IVC. Big trouble here. So that's why. That's actually its own grade. So there's 6 grades of liver trauma. A grade 5 is actually a retrohepatic IVC injury. Grade 6 is it's completely avulsed, so I could just open the abdomen and throw it in the bucket.
Is that the one where when you lift up the liver, you kind of see that like massive?
Exactly. It's just back here and it's bad. And again, you've taken, most of the blood supply to the liver comes from the portal vein. So that's first pass metabolism from the portal vein. So most of that blood supply to the liver is actually coming from that, and it's mixed oxygenation blood versus the hepatic artery, okay? And then the liver is going to drain directly into the IVC. So if you have that retrohepatic IVC injury, you're pretty screwed. There's a thing, anyone know what it's called? It's only talked about, no one really does it. It's a shunt, speaking of shunts, to try to fix that. Has anyone know? No, it's called a Schrock shunt. So you're supposed to do a right thoracotomy, open the right atrium, and put a chest tube down in through there, and then go down into the IVC below the liver to shunt the blood. Yeah, no, you're going to die. It's not going to work. But this is why, so spleens and livers are the same grade, grading system, but liver gets a 6 because of the 5 being the retrohepatic injury there. 1, 2, and 3 for injuries to the liver and the spleen are easy to remember because the laceration for 1 is less than 1 centimeter, for 2 is 1 to 3, and for 3 is greater than 3. So those numbers are super simple. And then your subcapsular hematoma is less than 10%, 10 to 50, and then greater than 50. So that's 1, 2, and 3 for liver and spleen. But back to there, sorry. This is how this happens. So transjugular intrahepatic portocaval shunt. So now, because of the cirrhosis, you're going to shunt, and IR does this, you're going to shunt the portal blood into the systemic system. What's the problem that you can develop with a TIPS procedure? Yeah, you get high levels of ammonia that are going directly to the brain, and then you can get encephalopathic from this. But cirrhosis is a really big problem, right, guys? So liver transplant, does anybody know then what this is? I would actually need a refresher. Yeah.
Oh, the MELD score.
Yeah, so you calculate a MELD score, and there's another score too. Yeah, Jesus Christ. Yeah, the other one. So there's two. Pull them up. So there's two scoring systems for the liver. But this is important because this is somebody that then has developed portal hypertension. And like we talked about the other day about mesenteric ischemia, the outflow problem here is if you develop a portal vein thrombosis. And who's a patient that not only gets cirrhosis, but can also develop a problem with this organ that sits here that can also predispose you to portal vein thrombosis? The alcoholic with chronic pancreatitis, okay? Because the splenic vein and artery run literally right with the pancreas there. Okay. So did you guys pull that up? MELD and the other one?
The child pew.
Child pew, yeah. And which is for what?
Well, child pew just says it's useful in the prognosis of patients with cirrhosis.
Yeah, so you're giving them like a, survivability. And then MELD is for actually transplantation, no?
Yeah.
Yeah, what are the components of a MELD score? So a contraindication, someone asked me this, a contraindication to transplantation, solid organ transplantation, is metastatic disease of any kind. So that's a contraindication. What would be the components of MELD?
It has whether you get dialysis.
Oh yeah, so again, now you're developing a hepatorenal syndrome. So yeah, are you on dialysis? That's bad.
Your creatinine, your
Okay.
bilirubin,
Billy. INR.
and sodium is like the more updated one.
Yeah, so sodium's always, whenever you're hyponatremic, it's bad news. What's the lab thing for necrotizing fasciitis that we use?
No.
No, there's a scoring system for necrotizing fasciitis. No one's heard of that one? So it's called the Linrix score. It's a laboratory risk indicator for necrotizing fasciitis. So it's the same thing, you go on MedCalc, but a component of that is, it's very similar to this actually. So it's like your renal function, glucose, because glucose is an important one, especially we were just talking about Fournier's gangrene.
Yeah.
Fournier's gangrene is neck fascia of the perineum, and it's always going to be in an uncontrolled diabetic. But what the heck was I saying? The sodium though. Sodium is, the second you see someone becoming hyponatremic from any disease process, it's not good. So in the Linrix score, that's one of the ones, and I take that into consideration. One of the ones in the Linrix, so it's a laboratory risk indicator for necrotizing fasciitis. One of the annoying ones is a CRP. We don't get that regularly, and it's like a send out, so it's kind of annoying, but you can take all those other components, and then what's going to be most important for evaluating somebody with neck fascia?
Clinical exam?
Yeah, like your clinical exam. What's the buzzword for neck fascia? That's it. Okay, that's a good one. That's a good one. What else? There's another like super classic thing that they say about the drainage from the wound. So it definitely smells bad. It smells dead.
Oh, yeah.
What's the buzzword though? Dirty dishwater. Yeah, it's dirty dishwater drainage from a wound, neck fascia.